afternoon, everyone. Welcome to Public Health Ontario Rounds in honor of World Tuberculosis or TB Day 2024. So my name is Dr. Leanne McDonald. I'm a public health physician here at Public Health Ontario, and it's my pleasure to be moderating today's session on clinical and public health approaches to pediatric TB. I'd like to start with the land acknowledgement. I acknowledge and respect the lands, sky, and waters of Ontario, including for their contribution and sharing to support all life within. I acknowledge and respect the treaty, unceded, and traditional territories of all First Nations across these lands and waters. I acknowledge and respect the traditional territories and communities of the Métis Nation of Ontario. I acknowledge and respect Inuit connection and contribution across these lands and waters. Please join me in acknowledgement and respect of all Indigenous peoples. May their wisdom always guide our own paths forward with open hands, open hearts, and open minds for the mutual success and benefit of all in Ontario. With thanks to Daniel Claire Coles for sharing this land acknowledgement. So now I will move into a few housekeeping items. And this is, as per routine, we will have the chat pod disabled to limit distractions, but we will have the Q&A pod open throughout the session. So please do enter your questions, and we look forward to the discussion and the question period that will follow the presentations today. And we will strive to get to as many of the questions that you share as possible. If you have any technical problems, please email capacitybuilding@oahpp.ca. And on my own behalf, I'd like to state as moderator, I don't have any conflicts of interest to disclose, but per my routine disclosures, I'm employed at Public Health Ontario. I have received support to attend residency program events at Queen's and NOSM, and I have been part of CHR-funded research, including on tuberculosis. So now it's my sincere pleasure to introduce our wonderful panel of speakers, Andrea Saunders, Dr. Ian Katai, Ranka Joshi, and Dr. Gayane Hovhannissian. Andrea Saunders is a communicable diseases specialist in health protection at Public Health Ontario. She's worked as both a nurse and an epidemiologist in TB prevention and care at all levels, local, provincial, and federal in Canada, and is a graduate of Public Health Agency of Canada's Field Epidemiology Program. Dr. Ian Katai trained in medicine in South Africa, in pediatrics in the UK, and in pediatric infectious diseases in Toronto. He worked for Oxfam in the UK, Oxfam UK in rural Zimbabwe, and with the Northern Medical Unit of the University of Manitoba. He is the TB specialist at Sick Kids, professor of pediatrics at the University of Toronto, and has been first or senior author of the pediatric chapters of the last 3 editions, the 6th, 7th, and 8th editions of the Canadian TB Standards. Ranka Joshi is the manager of the TB program at Peel Public Health. She worked as a pediatric nurse for more than a decade before becoming a public health nurse within vaccine preventable diseases and tuberculosis case management. And finally, Dr. Gayane Hovhannissian is joining us for the Q&A and discussion today. She is an Associate Medical Officer of Health at Peel Public Health as well, where she's responsible for TB, sexual health, and hepatitis portfolios within the Communicable Diseases Division. And Dr. Hovhannissian graduated from the Yerevan State Medical University in Armenia, completed her residency training at McMaster in Public Health and Preventive Medicine, and also obtained a PhD in epidemiology from the Dalla Lana School of Public Health at the University of Toronto, where she's appointed as an adjunct lecturer. So what an esteemed group we have. None of these speakers have any disclosures of conflicts of interest. And I'll just briefly review the objectives for today and the outline before passing it over to Andrea. So by the end of today's session, we are hoping and expecting that you will be able to describe the recent epidemiology of TB in Ontario, including in children aged 0 to 15 years. That you'll be able to identify aspects of the clinical presentation, diagnosis, and management unique to pediatric TB, as well as key aspects of public health management unique to pediatric TB, including source case finding, as well as contact investigations. And then finally, you'll be able to consider how collaboration between local public health organizations and clinicians, entities that are both represented here in our speakers, can support TB case and contact investigations involving children. So we'll start with the epidemiologic overview, move into clinical presentation, then public health management, and finally the discussion period. Over to you, Andrea.
Thank you, Leanne. So before we delve into the Ontario-specific data, we've gleaned from the published literature that globally, just over 1 in 10 cases of TB disease occur in children under 15 years of age. In countries with a low incidence of TB, like Canada and the US, this proportion is closer to 1 in 20 cases. Although the majority of these childhood cases are born in Canada or the US, one or both of their parents were most likely born outside of the country. Additionally, studies have shown that travel to a high TB incidence country may be a risk factor for the acquisition of TB for children born in low TB incidence countries. The next 5 slides present data that were extracted from Ontario's Integrated Public Health Information System, or IFIS, on March 6, 2024. And this figure shows how the provincial incidence of TB has been increasing steadily over the last 10 years. In 2023, close to 900 cases of TB disease were reported in Ontario, which is an almost 50% increase compared to 2014, and corresponds to an incidence rate of 5.7 cases per 100,000 population, which is the highest incidence rate reported in Ontario since 2003. And although it's difficult to see the green bars at the bottom of this figure, on average, between 2014 and 2023, children under 15 years of age accounted for 2.5% of all TB cases in the province. This slide shows the number and percentage of active TB cases under 15 years of age, stratified by 5-year age groups. And due to the small numbers, the proportions are quite variable, but overall, close to half of all TB cases reported between 2014 and 2023 occurred in children less than 5 years of age, followed by those 10 to 14 years of age and those 5 to 9 years of age. In 2023, 27 cases of childhood TB were reported in Ontario, which is an increase of almost 50% compared to the average of 16 cases reported annually between 2014 and 2022, and is in keeping with the overall increases we observed in 2023. If we compare the overall proportion of TB cases in those under 15 years to those 15 years of age and older by provincial regions, for the last 10 years, 4 regions, Central West, Eastern, Northwest, and Northeast, reported a significantly higher proportion of childhood TB cases when compared to Toronto, which accounts for over 40% of all provincial TB cases. In the northern region of the province, which includes both Northwest and Northeast, over 11% of all TB cases occurred in those under 15 years of age, compared to only 2.3% for the rest of Ontario. Looking at origin of birth, compared to TB cases in those 15 years of age and older, childhood TB cases reported in Ontario between 2014 and 2023 were significantly more likely to have been born in Canada. However, of those born in Canada, those 15 years of age and older were significantly more likely to be Indigenous compared to those under 15 years of age. Indigenous identity data are vital for the identification and monitoring of health inequities that stem from colonialism, racism, bias, and discrimination, and to inform the design of programs and services to reduce inequitable health outcomes. PHO includes data and analyses on Indigenous peoples to bring their experiences of health disparities and harms to light, and we continue to strive to build processes and relationships to respectfully and meaningfully analyze and report on Indigenous data. With respect to the site of infection, childhood TB cases reported between 2014 and 2023 were significantly more likely to have respiratory TB compared to cases in those 15 years of age and older. In particular, children under 15 years of age were significantly more likely to be diagnosed with TB of the lung and primary respiratory TB compared to older cases. However, as shown in the second figure on the right, the proportion of childhood TB cases with respiratory TB decreased with increasing age. And by 10 to 14 years of age, there is almost a 50-50 split of respiratory and non-respiratory infections. And to briefly summarize, we found that on average, children under 15 years of age accounted for 2.4% of all TB cases reported in Ontario between 2014 and 2022, but increased to 3.1% in 2023. Compared to TB cases in those 15 years of age and older, childhood TB cases were significantly more likely to have been born in Canada and to have been diagnosed with respiratory TB, although the proportion of childhood TB cases with respiratory infection decreased with increasing age. And finally, although not presented previously, close to 1/3 of childhood TB cases in Ontario with available risk factor information reported living and/or traveling to a high TB incidence country. We've provided a list of the references that we've mentioned in the previous slides. And with that, I will hand things over to Dr. Katai.
Thank you very much. I hope people can hear me. And thanks. This is for the great talk, Andrea. This is a good segue to many things I want to deal with. And one of the important updated ones is the high incidence of extrapulmonary TB in older children and adolescents. I'm going to try, I've been asked to do a kind of quick clinical intro into pediatric tuberculosis. Apologies to those who've heard me talk because you'll probably have, this isn't new to you. So the usual disclaimers about publication of these slides, they're my own. I talk about childhood TB in those under 15 years of age and pediatric TB in those who are less than 17. So just to run through the talk briefly, I want to contrast childhood and adult TB. They tend to be different sorts of disease. I want to talk about the age-related presentation of TB in childhood and its immunologic correlates, talk about diagnostics in young children, and then talk about adolescents who are a really under-researched but very important group, adolescents and young adults, for many reasons, including their attendance at congregant settings and their ability to spread TB, and then discuss some missed opportunities for diagnosis. So this is typically what we would think of, what many people think of as tuberculosis. Here's an adolescent or young adult with often a prolonged history of cough, fever, night sweats, weight loss, upper lobe, air-space disease, very important discriminating feature. In fact, bilateral disease, diagnosis easy to make by way of sputum. The next slide really tries to contrast adult TB on the left with extensive parenchymal lung involvement with childhood TB. So typically adult TB has typical symptoms, cough, fever, night sweats, weight loss, is often pulmonary, but can be anywhere, really important, is often multibacillary. So you can get sputum out of the adult, smear it, stain it, make a diagnosis quickly. And you have an endpoint for treatment because smears and cultures convert to negative. So you know you're succeeding. Whereas, especially in very young children, TB may be non-specific. So here's a child with TB meningitis who has hydrocephalus and leptomeningeal enhancement. And on the right of that is an example of a contact, a child who'd been in contact with TB with a large hilar lymph node. That child may be asymptomatic, in fact, and we'd start treatment and may stay asymptomatic. Or it's a paucibacillary disease by and large. We have a heck of a time growing TB, one bacillus out of that child. And in most series, 40–50% of such children will be culture negative, even though they have TB and respond well to treatment. And repeat specimens are difficult and unreliable. So the question around childhood, young children childhood TB is children are typically the recipients of TB from adolescents and adults with pulmonary disease and an extensive cough. And children, I'm sorry, I'll go back to that. Children are seldom infectious. So this child with hilar lymphadenopathy in the bottom right is not infectious. Whereas here are examples of the top two examples of children who've been infectious to others. But these children have essentially adult type disease. Certainly this child on the left does. He's got a cavity, although he's 9 years old, and he infected a large number of bus riders in, I think, North Dakota. And on the right is a child with miliary disease, but a cavity whose endotracheal aspirates were studded full of TB bacilli, and he infected his parents and healthcare workers who were close to him, not so much people further away. I want to now talk about presentation, and there's an overlap, but the very young, less than 5, especially less than 1, may have miliary TB, but also a bunch of other things, pulmonary, extrapulmonary, and importantly, TB meningitis. The young child has what could truly be talked about as the primary complex, a focus in the parenchyma, but regional lymphadenopathy and its complications when it comes to intrathoracic TB. And the older child and adolescent, and Andrea alludes to this, can have protein manifestations, many of which are extrapulmonary, and that's one of the reasons for late diagnosis. And there is this overlap. So here's a very young child who happened to be nosocomially infected at Sick Kids Nursery, who presented within 2.5 months of that infection with life-threatening TB, a pertussis-like cough, hemophagocytosis, often on months in ICU, and did very well. Ultimately, at the end of a year, he was entirely well. He saw us every year until he turned 18. Partly, the parents wanted him to be seen to teach people. And the lesson from him is young children really get very sick quite quickly after exposure. The major risk factor for his severe disease was his young age. And we've talked about TB meningitis, the feared complication. This child happens to have a paratracheal node, which is a clue, but hydrocephalus at presentation is. And remember, that's not sudden stiff neck. That's slow behavior change, headache, a number of things. Late diagnosis is very common. And the outcome is basically lousy. This great systematic review by Sylvia Chung really says that even without neuropsychological testing. Now, here's a child who I think illustrates many things about TB because they presented with an acute abdomen, and on laparoscopy they were found to have miliary studding of the peritoneum. And in fact, by looking at the address, public health worked out that there was a known contact, and the contact, for complex reasons, had not declared that there had been other children in the apartment in which that contact lived. This is an exception in Ontario. So when I worked in Africa, I saw far too many young children damaged by TB. And we as clinicians are all part of the picture because we work in a milieu where public health does its work really well. And if it's done really well, the young contacts are found at an early stage, they're evaluated and put on treatment to prevent TB, we will not see severe TB like in this child. And we are blessed in Peel, in Toronto, to have that public health infrastructure. And erosion of the public health infrastructure will always lead to bad things in young TB. So the messages here are young children get sick from TB. Childhood TB is a sentinel event, which implies source. There's a source case somewhere. Where's the adult? Where's the adolescent? You've got to find them. And there's transmission. And teams and systems are needed to prevent pediatric TB. And if you get lots of childhood TB, it implies ongoing transmission in the community. And going back to Andrea's talk, the fact that in Northern Ontario, we're now seeing young children with TB really points to a community-wide problem. This is the classical summary by Ben Murray of the pre-chemotherapy literature, and it informs much of what we do in TB. Because it says, looking at work from Edith Lincoln and others years ago, if you are infected under a year of age, there's a 10 to 20% chance of TB meningitis or miliary TB. And as you get older, that chance really goes down. And your best time to get infected in life turns out to be 5 to 10. These are the golden ages. And so we often draw a line at about under 5 to worry about the risk to the child who might be infected of TB meningitis or miliary TB. And there's a recent meta-analysis that didn't look at the more severe forms, but really says about the same thing, that says if you're infected under 5 years of age with a positive TST or IGRA, there's still around a 20% chance of disease, which is significant. And why? Well, so this paper by James Seton really looks at others. The TB risk in the first 3 to 4 years of life is very high. Then it goes down from 5 to 10 and then climbs during adolescence. There are hormonal and other factors, but most importantly for the young child will be immune differences, which include a Th2 rather than a Th1 response, impaired dendritic cell function, impaired macrophage numbers and function. And so young children have an immunologic vulnerability. So managing young contacts is the most important task we have. We evaluate them clinically. We do tests for infection at TST or IGRA. And if they're TST positive or IGRA positive, we'll make sure they don't have disease and otherwise treat them for TB infection or latent TB infection. But it takes up to 8 to 12 weeks after the break in contact to develop a positive TST or IGRA. And so for the young children, rather than anyone over 5, we're liable to want to put that child on a regimen as if they are infected. We call it window or gap prophylaxis until we can prove they're not infected by that TST or IGRA 8 or 10 weeks after that break in contact date. Now, when we go on to older children or intrathoracic disease in children, this was a child I was suspicious there was something going on in the hilum. At the time, I'd ordered a CT, something I probably wouldn't do now. I might have just treated this child. And indeed, this is the classical GON focus. Here is a parenchymal infiltrate, and adjacent to the lymph node is an airway. Most of the time, this will heal up, but in fact, it may cause collapse of that airway and other complications. And there are international classifications for research purposes for childhood TB. This child with bilateral hilar lymphadenopathy, the lateral shows a nice ball of nodes. We happen to culture TB, so we can call that confirmed TB from a gastric aspirate. For many children, for instance, we know the parent has TB. Here's someone with a classical hilar lymphadenopathy and a positive skin test in the Canadian-born child. In those who've had BCG, we enormously prefer an IGRA and have great data to support that. And we need publicly funded IGRAs. I'll say it to this group now because we need as much pressure for equity and other reasons. We need them. But this child we might treat for TB disease just based on the X-ray appearance and the fact that they're infected. There are tricks and catches in pediatric TB. There's an apparent difference between these before and after X-rays, especially in the right hilum. It turns out they were 1.5 hours apart. This child had a normal lateral X-ray and was slightly rotated, and any rotation of the chest to the X-ray beam is likely to give you this false impression. So good radiology and good radiology reporting is important. And very briefly, in terms of diagnostics, in some high-burden countries, they will do induced sputa in very young children. We do them in anyone who can expectorate 6 years and up. We've had positive results, including the child whose X-ray is on the right. In some high-burden countries, they would give normal high protonic saline, and they'd do suction of whatever the child's coughing up. We don't do that for a bunch of reasons and don't have the critical mass, but we use gastric aspirates for many of our children and actually have good yields, not great yields, but good yields. So that's a little introduction to childhood TB, and we can talk more about other aspects. But I now want to go on to, we know from guinea pig models and otherwise that following that primary complex, there's a basilemia that disseminates to many areas. And these can become the sites of activation, or they can progress quickly. And so when we look at the older child, I think the message is, if people ask me, can TB cause, I always say yes. I don't wait for the next word. But there's some syndromes that are more important. So lymphadenitis, here's a child with an adolescent with that classical purplish discoloration of a lymph node. Could be from a non-tuberculous mycobacterium, but if they have risk factors for TB, it could well be TB. This is an unusual spirotrichoid presentation with cold abscesses running up the arm. Here's someone, Sarah Winter, who was thought to have Crohn's disease because they had a thickened terminal ileum, a stricture there, but they had hypoechogenic nodes, and this turned out to be TB. The person on the left was thought to have metastatic brain tumors, but turned out to have multiple tuberculomas. The person on the right has an isolated tuberculoma. And this shows many of the presentations of TB in adolescents. So running clockwise, the rib lesion, actually someone thought was a Ewing sarcoma, but it isn't. The person with the plastic peritonitis was initially thought to have a carcinomatous spread. You can see a psoas abscess with vertebral involvement. Still going clockwise, someone's lost their entire vertebra. And finally, we end up with the adolescent with classical pulmonary TB. And I show you that because Andrea had that great, this is old data, one of Priya Pangsmat, one of our great fellows now in Thailand, did the study, which said that if you're 13 to 17, your chances of having pulmonary disease are about, isolated pulmonary disease are about 50%, but extrapulmonary manifestations are common. And so for the adolescent, yes, upper lobe disease and failure to get a sputum quickly and send it for TB culture is the most important mistake. Bilateral upper lobe disease, yes, upper lobe, posterior segment of the lower lobe. Fatima Al-Dubisi did the study in RED, which said if you had more than 10 days of fever, more than 13 days of cough, that had pretty good discrimination of TB from pneumonia. But here's someone with lower lobe disease. Someone who trained me in Southern Africa said, if you're looking for upper lobe disease, you're being greedy, just send the sputum. She had good going TB, and it took 3 months to make that diagnosis. So April Tam reviewed our early data with adolescents. Lack of clinical suspicion was the big problem. A median of 5.5 months to diagnosis, very protean. Mood disorders were common. School investigations are a huge problem for the adolescent. It's very difficult to preserve privacy, and it's a very difficult age. So pulmonary disease in the older child and adolescent may present as unresolving pneumonia, pleural effusion with or without a parenchymal infiltrate, upper lobe disease, any lobe disease, cavitary and non-cavitary disease, and get a sputum is what we would say, and send it for TB culture and smear quickly. And so I'll end with some missed opportunities for early diagnosis of pediatric TB in Canada. Failure to consider epidemiologic history. In our context, in the Toronto area, it's, yes, foreign-born children and adolescents, but the children of foreign-born parents. And for Canada, remember Indigenous failure to obtain sputum, failure to send biopsy specimens, not considering TB because the TST or IGRA is negative. Remember, up to 30% of people with TB disease may have TSTs or IGRAs, and expecting pulmonary disease. And then failure to consider TB in the following circumstances: poorly responding pneumonia, a pleural effusion with or without parenchymal change, hydrocephalus and meningitis with negative bacterial cultures, and a prolonged fever in the returning traveler. We are all part of a team. This is the team that I'm very privileged to work with. Many of you know Ray Lam, the nurse practitioner from Heaven Sent. Here is the translator on wheels, which is critical. Peter Bikangaga helps us with our patients in Peel, and we're so fortunate. And Colleen Heimer's a social worker, essential on our team. Thanks. I will hand over to the next speaker, and thank you for listening.
So I'm going to quickly talk about some public health management as it relates to pediatric TB. I'll start by saying that in the interest of time, I won't be outlining case and contact management in detail. I'll really only identify the key differences when children are involved. I'll have essentially one wordy slide on key principles to consider when dealing with kids, a few slides on the differences, and then 2 quick case studies that I hope will illustrate all of the principles. I have no conflicts of interest to declare. Okay, so what are the key things to keep in mind when we are dealing with children? 1, as we heard from Dr. Katai, children are more vulnerable to both infection and development of active disease. 2, in Canada, and certainly we see this in Peel region, most kids with TB are diagnosed via contact follow-up. Children diagnosed with active TB disease and latent tuberculosis infection are most often household or close non-household contacts of an adult with TB. This is almost always the case for our Canadian-born children, though certainly kids can be infected in an endemic birth country prior to arrival in Canada or through travel to an endemic country. 3, an ounce of prevention is worth a pound of cure. So because most kids are contacts of adult cases, we really want to do what we can to prevent transmission, to prevent infection, and to prevent progression to active disease. From a public health perspective, this is ensuring the source case is isolating and emphasizing contact screening. Oftentimes, the adult source case has been infectious long enough for transmission to occur well before we know about the case, so you can't always stop that. But in that case, our job in public health is to decrease the risk of developing active disease or catch it and treat it early to decrease morbidity. 4, pediatric cases and contacts require extra support from public health. There can be a lot of anxiety around exposure, as well as about screening and treatment. Parents have a lot of anxiety about invasive tests like TB skin tests or IGRA blood draws, and can struggle with providing medications to kids, particularly infants. Additionally, access to care at all can be difficult in some regions. Certainly, we're underserviced in Peel, and a lot of our population are unattached to primary care, so public health needs to work extra hard to ensure physicians, parents, and caregivers all understand the importance of screening. We can help facilitate screening and ensure referrals to TB specialists. Finally, screening, diagnosis, and treatment of children works best when public health units and clinicians and the community work as a team. Having coordinated care to make the experience as easy and timely as possible for clients and families is important, and it's really helpful to have multiple people with the same messaging and education in order to counter some of that anxiety. So we're going to look at some of the few key differences in case and contact management when children are involved. For older children and adolescents, there's not many differences. Older children with respiratory TB can be infectious and require isolation, just like adults. And they will need contact investigations as per the established guidelines, just like adults. We'd like for them to be treated by a pediatric specialist, but when they're older, 17, 16-year-olds, they can be treated by an adult specialist. Generally, we do provide more directly observed therapy support than to our adult cases as well. DOT is individualized for adults, but our cases under 18 years of age all start with 5 days a week DOT. So where we see the most differences is in this younger age group, the under 10 years of age. Children with respiratory TB under 10 years of age are generally not considered infectious unless they have an adult presentation. They're smear positive or have significant disease. So isolation may also not be required. Like older children, they're seen by pediatric specialists and receive daily directly observed therapy support. Because they're generally not infectious, by extension, a contact investigation might not be required. But we do something called a source case investigation for our very young clients. This is completed for cases less than 5 years of age, unless the source case is known. For example, you know the child is a contact of their father. The goal of this source case investigation is to find the adult who likely infected the child. And I just want to note that this investigation is not always successful, and it's difficult to confirm. Most of our pediatric cases less than 5 years of age are clinical cases. They reflect household contacts of adult TB cases. They're found on contact screening to have an abnormal chest x-ray. Rarely do we actually have lab confirmation, so we usually can't confirm the link through something like genotyping. Similarly, we may, through source case investigation, find that the child was in close contact with a visitor, for example, a grandmother, who has since been diagnosed with TB upon return to their home country. In those cases, we can assume that that's the source case, but we can't confirm it, especially if someone else in the home might also be infected. Finally, in terms of pediatric contacts, the biggest difference with respect to children is in the very young contacts of a case, those less than 5 years of age again. Because kids are more vulnerable to infection, we have a lower exposure threshold for these children. And because TB can progress rapidly in young children, screening involves a chest X-ray, regardless of TB skin test result, because we want to ensure that our really young contacts are screened for early signs of active disease. We recommend specialist referral and protection with antibiotics with window prophylaxis between the first and second skin tests. So now just a couple of quick case studies. This case study outlines what can potentially happen when child contacts are not screened and public health isn't able to do their job effectively. Here we have a 30-year-old male with pulmonary TB. His AFB is 4+ and he has cavitary lesions, so he's high infectivity. We identified 10 household contacts between 2 families in the home, including a total of 7 children ages 10 months to 6 years. Both families were quite resistant to his screening initially, and we learned that some of the contacts were out of the country for an extended period of time, so screening was going to be delayed right from the start. The case manager worked really hard to provide education, reassurance, offered to do skin testing in their own home, and arranged for specialist referrals to see all of the kids. In the end, the families, though, did not get their screening or show up to any of their specialist appointments. They were counseled on the risks and what to do should anyone become ill, and eventually, after a number of months, their files were closed, lost to follow-up. Now, screening isn't required. Public health needs to notify contacts that they've been exposed, provide education and recommendations for screening, and try hard to facilitate that screening, but we can't force someone to be screened. Now, 6 months later, one of the contacts, a 3-year-old, developed respiratory symptoms. The mother, remembering the advice she received, went to the doctor and told them about the exposure and requested a TB skin test for the child, and that was positive. They were given a chest X-ray requisition by the doctor, but unfortunately did not have it completed for another month. When it did come back abnormal, it and the TB skin test result were reported to public health as a suspect case of TB. The child was referred to sick kids immediately, along with their siblings. The 3-year-old was diagnosed with active TB disease, and both of their siblings were diagnosed with latent tuberculosis infection. It was only at that time that the children less than 5 years of age in the other family in the household were screened. The 6-year-old was not. At that time, 2 of the children were diagnosed with LTBI. All of these children went on to be treated, and all received some form of directly observed therapy or directly observed preventative therapy to support successful treatment completion. They received assistance with travel to appointments and other supports. 18 months after initially being diagnosed, the index case reactivated, and at that time the last child was screened, and they too were found to have LTBI. Now, obviously we can't say that none of these children would have been infected had they been screened originally. With high infectivity in the young ages of the contacts, they very well could have. But there's a good chance that, had the kids been screened and treated for LTBI or given window prof, the 3-year-old may not have developed active disease. I'm going to use this case to demonstrate the importance of collaboration with stakeholders and physicians to successful screening. So in this case, we had a young woman who was undergoing an immigration medical exam as part of a status change. She was asymptomatic and found to have an abnormal chest X-ray, showing some opacities bilaterally. She had several sputa collected, only one of which was AFB positive few, but confirmed M. tuberculosis. She was low infectivity. She was a recent graduate of an ECE program and working in a Montessori school at the time of her diagnosis. Thankfully, she had no clinical placements during her period of infectivity. It was determined that she had spent enough time at work in the toddler room during her period of infectivity to warrant screening. 15 children between the ages of 18 months and 3 years were identified as contacts. And a reminder, the recommendation for this age group is an initial and repeat TB skin test, a chest X-ray, and referral to a specialist for window prophylaxis. So essentially we had 2 options for screening for these children. One, we could do an on-site TB skin testing clinic. The benefit of this option is that we would have a better chance that contacts would be screened appropriately since we were doing the screening, and it provided a chance to speak with parents and guardians that were in attendance to provide some education and answer questions. The downside of this was that there were very young children, so they can be difficult to test. They may require more resources than a typical clinic and would require parental involvement, so parents would have to take time off work. And of course, there's always the possibility that it may cause concern or panic at the school. The other option was to contact parents and guardians individually through phone calls and letters to advise of the child's exposure and to provide recommendations to see their healthcare provider for screening, specialist referral, and window prophylaxis. Now, the benefit of this option is that because children this age should have a chest x-ray, they would need to see a healthcare provider for that requisition anyway, so it could potentially mean fewer appointments. It might be less disruptive for the families. They can make appointments around their own schedule. And certainly it would be less disruptive for the school. The downside to this, and it was a big one, is obviously we have less control over the screening. It's up to the parents or guardians to take the kids to be tested. And as we saw from the last scenario, that doesn't always happen. Given how young these contacts were and their vulnerability, we decided we needed to do everything that we could to ensure that they got screened. So we determined the best option was to conduct a TB screening clinic at the school. Now, unlike a high school or workplace clinic where you really only need to worry about doing the actual skin test, we needed to make sure that these contacts also received a chest x-ray, were referred to a specialist, and offered window prophylaxis as part of their screening. To make this as easy as possible for parents and to give us our best shot that the families would actually follow up with those other recommendations, we collaborated with one of our amazing pediatric respirologists in Peel. He agreed to see all of our contacts, and in fact, he opened his clinic on a Saturday, about a week after our planned clinic, to see everyone. He provided us with chest x-ray requisitions that we could give to each parent at the time of TB skin tests, and we provided instructions on where to go and how to get those completed. We also worked really closely with the school administration to get a sense of the school population, provide education and messaging. Now, normally when doing a school clinic, we'll often have general messaging for the whole school, but in this case, the school felt that there would be a lot of concern and talk amongst the families in this very tight-knit school. We determined, based on the school culture, that the most effective way to communicate initially with families about the exposure and the clinic was to have that messaging in letters created by public health, but to have those letters hand-delivered by the school administrator, who had personal and high-trust relationships with all of the families. Doing it this way allowed for more discretion and eliminated any panic or gossip at the school. And we felt families would be more receptive to the information as well. So we provided letters, consent forms, fact sheets, and information on booking the appointments with the specialist to the school for delivery to the parents, and we had all of the questions and concerns directed to me as the case manager. So what happened? Well, all children did have an initial and repeat skin test, so that was a success. In our initial clinic, we screened 11 kids of the 15, and 4 had screening completed through the healthcare provider. 4 families declined the initial chest x-rays. Many of the families were concerned about safety, radiation exposure, and the need for the chest x-ray, but in the end, with education, most of them did agree to have the chest x-ray completed. Generally, those that declined the chest x-ray also declined specialist appointment, and as a result, did not receive window prophylaxis. Initially, there was a lot of education that needed to happen around window prof, but 8 of the families that saw a specialist initially did accept the medication. Unfortunately, in the end, only 2 children started and completed the window prof. Through discussions later on with families, we learned that after agreeing to the window prophylaxis, there was a lot of discussion amongst the families themselves about whether it was necessary, what others were doing, and why, which eventually led to most of them changing their minds. As mentioned, though, all children did have a repeat skin test and all were negative. We didn't hold a clinic for the repeat skin tests as the timeline fell in the summer when the school was closed. So we worked closely with all of the family's various healthcare providers about the need for screening. Most of the children did go to their own healthcare providers, but we did provide repeat skin testing for 1 child. So I think that scenario and the previous one provide a pretty good sense of those key principles in action. The fact that kids are usually contacts of adults, contact screening is key, as is support and collaboration. So that's it. Thanks very much.
So I will just start by saying a huge thank you to our panel of presenters who has just provided an excellent spectrum of considerations on epidemiological, clinical, and public health management fronts of pediatric TB. So we're going to shift into the Q&A, really only just a couple of minutes earlier than we typically do. And I can see we already have a few questions in the Q&A pod, so you can please continue entering them now. And I would invite our wonderful presenters, Dr. Ian Katai, or Andrea Saunders, as well as our discussant, Dr. Gayane Hovhannissian, and Renka when she's able to rejoin. I see her rejoining now to just, I'd invite you to turn on your cameras. Renka, it's great to see you back. We're going to just shift.
Sorry about that.
No worries. This happens. So we'll take the opportunity to shift into the Q&A, and then we can see if we can have a little bit of time at the end for anything you wish to highlight from the case studies. How does that sound? And we can, as per usual, share the slides and make sure that our audience benefits from learning about the case studies in detail. Okay, so I have the pleasure of reading out some of our questions, and please do keep them coming. I see we have lots of participants still on, and we have some good questions coming in. So the first one, Ian, is a clinical question for you. Do positive gastric aspirates always indicate pulmonary TB, or is there a chance that abdominal TB could prompt this result?
It's a good question, and yes, I think you'd have to probably posit either that there's TB affecting the stomach or esophagus, or that there's retrograde spread. So certainly that's true. I should also highlight one of the things that internationally is big is now looking at stool in young children. So stool expert we don't have, unfortunately, in many places in Ontario. We have a great PHO lab, but we need expert. So a quick molecular test in expert has about 50% sensitivity compared to respiratory specimens, but it's huge because it's easy to get. You don't have to go through. So it's a very good question you have. And in fact, we're looking at that right now. And many of our stool positives also have abdominal involvement. So yes, it could, is the bottom line. But a lot of the time we're getting these positives when there's just intrathoracic lymphadenopathy.
Thanks so much, Ian. And you've already started to address another question that is about commenting on stool testing for diagnosis in children. Is there anything else you'd want to add on the stool testing front?
No, so I think there are two things. One of which is, which we're currently looking at, is the yield on stool testing. And I would encourage, since we've got public health on the line, if you've got a client waiting for an appointment, I see nothing wrong with sending its stool for TB culture. Now, we don't want to flood the lab, but with respiratory disease in adults, we may pick something up, and lack of a quick culture is important. So I think stool testing is important. It's especially important where there's abdominal TB, and it's easy and quick. You don't want to send ridiculous number of specimens in low yields cases to the PHO lab. I can't speak to Angela. I'm not sure if she's on, but I would still say it's an important extra way of getting a culture, and especially in pediatric TB, we often are stuck with the lack of a positive culture.
Thanks
but we
so
need
much.
an expert. Yes.
Thanks so much, Ian. Okay, I'll shift to a public health management and IPAC related question. So there's interest in some of the comments about not isolating children under 10 years, even sometimes in the context of TB pulmonary disease, and a follow-up question around implications around IPAC and hospitals or guidance around that. So perhaps I'll open it up to my PL colleagues to comment, and Ian, if you would like to add in, that would be great.
Yeah, I'll just start. So may not need isolation. So it's certainly dependent on their age and their clinical presentation. For the most part, we don't see too many kids sort of 8, 9, 10 years old with pulmonary disease anyway. We tend to see those younger children. So these little 2-year-olds, 4-year-olds, 5.
Ian, did you have anything to add? So I think Renka was speaking about this being an easier decision than much younger kids.
It's an interesting question. Oh, sorry.
Sorry, am I cutting out again? Yeah. I'll let Dr. Katai handle that.
We did hear some of your answer. Go ahead, Ian.
So really, in fact, if you ask the data, how strong the data is in terms of the number of outbreak investigations related to a 5-year-old or 10-year-old, it turns out it's very little. There's an old paper by Jeff Stark on first principles, which summarizes what we knew. On first principles, these children have porcibacillary disease, and the few data that they are say they generally have not transmitted to others. We've seen that also with newborns and others. So it's not completely established, but in general, the risk is much, much lower. If you say, what are the big determinants of being infectious? The biggest by far is smear positivity. It's very seldom. I mean, the literature there is rocks. It's very seldom you're going to get a positive smear with a cough in a young child. And most of that disease is going to be intrathoracic. So on first principles, we think it's pretty unlikely. But if you ask, have you got absolute data? My look at the literature some years ago said no. I still think it's generally true. And it should be on a case-by-case basis, I would say. But treating the young child, Jeff started this study in Texas, which was where they had young children with TB who they deemed on various principles to be non-infectious, but 15% of consecutive adult visitors to those children had undiagnosed pulmonary TB. So focus on the real risk, which is generally the adult and adolescent.
Thank you. Gayane, did you want to add to that as well?
Yeah, thank you. I think in terms of the isolation, so the hospital setting or whenever children are attending any clinical settings, point of care risk assessment is necessary, similar to any infections that we have. So we leave that usually to our esteemed colleagues in hospital settings to use their judgment and understanding of the infection at that point in time to apply IPAC practices. But when we are in the community, and most of the time our involvement as public health unit, so we work with children in the community settings, and we need to make decisions about isolations and exclusions from various settings. So I think that's where it applies that, once the children are started on effective treatment and, usually we worry less about them transmitting infections. So I think that's the other piece. So not necessarily the IPAC from hospital perspective, but in the community. So for children that do not present with adult type disease, so we worry less about transmission of infection.
Thank you. So another question about transmissibility, perhaps open it up to Ian and then others. Is all TB lymphadenitis considered to be infectious to others? You're muted, I think, Ian.
Yeah, I am. I apologize. So if it's isolated TB lymphadenitis, it's very unlikely to be transmitted. It would only really be pulmonary. We have to remember Mycobacterium tuberculosis, the biggest killer of humans, infectious disease killer of humans by far with history, is looking for a single cell. It's looking for the alveolar macrophage. It teleologically has to be airborne because that's the site, that's the cell it wants to bind to. And I always say I can cut myself and rub TB material into the skin and I may or may not get infected because the affinity with other macrophages is much lower. And it's worth remembering that where has lymphadenitis become infectious? When people have sprayed high jet aerosols of saline or water into that cavity and aerosolized it. Aerosolization is the generally necessary precursor of infection because it allows the organism to find the alveolar macrophage. So by and large, yes, if it's discharging, it needs covering up, but it's our defense against TB. We often overdo infection control is an N95 mask and wash your hands. The gowns and gloves and everything. Anyway, that's my general view. So if it's isolated lymphadenitis, no, there may be undiagnosed pulmonary disease, which you might see on a CT, and certainly it's worth getting a sputum to make sure. But if it's just and then the question becomes, does one contact trace those? There may be a yield, probably because of some common exposure that's led to both, but that's separate.
Thank you. Ian, we have a number of additional clinical questions. So we have a couple that pertain to treatment regimens and formulations. So the first is if you could comment on any progress on child-friendly TB medication formulations. And then the second question is a more general question about how treatment differs, if at all, in children and adults. And that's a big question, but if there's anything you would like to highlight about both of those things, that would be great.
Okay, so firstly, child-friendly formulations. So the irony is that there are child-friendly formulations in tablet form that are scored, that are weight-banded, that are available in the world. Find and others develop them with the aid of Canadian aid money, but they are not available in Canada because it does not pay the companies to go through the licensure. So we face that all the time. Now, we can get by. We make suspensions, but for instance, rifampin suspension takes a day to make and is not that stable. We have a stable INH suspension, but it is a problem for dosing, especially in remote areas. And there looked like there was some movement with the feds and etc. And the MOH office, but I haven't seen anything happen since. I can send there's a piece, I was one of many authors from the US and Europe about this very issue somewhere in Lancet Adolescent and Child Health. But the bottom line is the licensure requirements make this very difficult. So we'd like better child-friendly formulations. We can get by, but we're always gerrymandering things. By and large, though, we cure TB here. So that's number one. Differences in regimens. I suppose some of the differences in regimens would be we use higher doses of isoniazid, but these are standard, and that's because of PK work largely done by the Stellenbosch group. We will drop ethambutol early, as now the adult guidelines will, unless we don't know sensitivities, although the risk of optic neuritis is very low. Can't monitor vision, that's one of the things. So for standard regimens, they're not. And I guess the other thing that people may know about is the SHINE trial, which was a trial of non-severe TB in both India and Africa, which suggested 4 months of treatment, which just takes off the last 2 months of INH and rifampin, seems to be non-inferior to 6 months. Some doubts. Still have some doubts on that. We've used it in very select cases with a whiff of something. Most of the toxicity occurred within the first 2 months anyway, so you're not buying toxicity, you're buying just less time you're involved with the child. So those are a few things regarding childhood regimens. The big problem with childhood is getting the medicine into the child. And that really is the struggle. And that's where our team and our nurse practitioners and her team and everyone else becomes so important and feeds back to us. But, the INH cannot be taken with food generally, although we make compromises. Rifampin shouldn't be taken with food.
Thank you so much. So there is a question about contact management, and there has been some written correspondence about it in the pod, but I thought we could just state it orally as well, because it's a good question. If you have a contact under 5 years old and the break in contact was over 8 weeks ago, the TST was planted and negative after the appropriate break in contact, would you still refer to a specialist for a chest x-ray? So I think there are two parts to this. Would you still refer for a chest x-ray, and to whom would you refer? And so maybe, Renka, I'll let you answer, and welcome others to comment too on this, because I think it's an important aspect of contact management to highlight.
Sure. I typed the answer thinking that my audio would not work. So we'll see how it goes. So generally, we like to have a chest x-ray done at the same time as a TST before they see a specialist, because it's easier that way as well for the specialist to proceed with their own appointment. So if they already were past their 8-week break in contact, we would still have a TST, we would still have the chest x-ray done, but we would not refer to a specialist because there's no need for window prophylaxis. That's the real reason for a specialist, is to prescribe and educate about that window prophylaxis and follow up. The only time we would, after that 8-week mark with a negative test, would be to refer to a specialist would be if the chest x-ray was abnormal. So for us, we like to have the chest x-ray before they are seen by a specialist.
Ian, do you have anything to add there? Okay, thank you, Rinka. Andrea, there's a question related to the surveillance trends that you presented on. So I'm wondering if you can speak to what we know and what we don't know about the trends that we're seeing, which, as the participant has noted, seem to have been increasing.
Thanks, Leanne. Yes, so obviously the data I showed earlier, we are seeing a huge increase in our TB case rates over the last few years, especially in 2023 compared to 2022. Unfortunately, we haven't been able to determine exactly what the factors are that are impacting this. Certainly COVID and the related restrictions on healthcare access and workforce capacity at the health unit level in terms of data entry and data collection, et cetera, have all played a role as well. And in addition to active TB cases, where we actually have seen the most impacts from the COVID-19 pandemic have been on the notification of latent TB infection, which dropped significantly during the first couple of years of the pandemic, but have started to slowly increase and are close to reaching pre-pandemic levels again. But I think this is also concerning given the risk of progression to active TB and missed opportunities for the detection and treatment of latent TB infection. But we are certainly continuing to explore our IFAS data to determine whether or not what additional factors might be responsible for the increases that we're seeing and whether or not these increases will continue into the next couple of years. But there's nothing obvious that has popped out as of yet as to a main factor or reason why we're seeing this increase, but it is concerning, of course. So we are continuing to monitor and look into it.
Thanks so much, Andrea. So I think that's an excellent note to wrap up on. So thank you so much to our speakers today, Andrea Saunders, Ian Katai, Renka Joshi, and Gayane Hovhannissian, and everyone who spent the past hour joining us in honor of World TB Day to talk about children and TB, a really important topic. So please, when you do get the anonymous brief survey, complete it and share input with us so we can continue to improve our programming. And if you're interested in the Ontario Public Health Convention, go to topic.ca. It's upcoming starting next week and in early April. As per usual, you can find our past presentations and learn about upcoming educational sessions on the PHO website. So go to Education and Events and then click on Presentations. And we just really thank everyone who joined us today and welcome your feedback and look forward to more PHO rounds on tuberculosis in the future. And happy World TB Day, everyone, on this Sunday.